everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Jaydira Therapeutics. My name is Rain Bennett. I am your host. It is my pleasure to be your host. And we've been doing this show now almost a whole year. I can't believe it. I think we've done 46 episodes. This might be our 46th episode. A few weeks off here and there for vacation and holidays and whatnot. If you don't know me, I'm a filmmaker that's been working with Carcinoid Cancer Foundation for a decade, since 2011, to create video content, produced videos that we have on our YouTube channel, as well as here on the Facebook page, and live video series like the one you're watching today, both with the same mission in mind, and that is to educate people and raise awareness about this disease, about neuroendocrine tumors. That is our goal. That is our mission. And I am not a medical expert. I'm just a storyteller and a filmmaker, but it's been one of my great pleasures of my career and my life to be a part of this community. And I appreciate you all welcoming me, and I appreciate the opportunity to share your stories. If you are a regular, a friend of the foundation and of the show, you probably know the drill, and you probably are already telling us where you are in the world. Hello from New Brunswick, Canada. From a few people from Canada. David from Cherryville, NC. Always a shout out to my North Carolina folks. I am here in Durham. And if you're a first timer, a rookie to the show, let us know where you are in the world. We love, and I love to see how far this show reaches every week. It's amazing to me how joining us live, people will be on all continents across the world, even when they should be sleeping. That's very impressive. Florian from Germany. Hello, Florian. Good to see you again, my friend. Germany's not looking so great in the Euros right now. I don't know what's going on. I'm a big fan of Deutschland. So quick announcement before we get started. Today is June 24th. This is our last episode for a little while. I was talking with our guest before we started the show today. She noticed my sharks on my shirt. If you are a regular here at the show, you know that this usually means it's party time. I'm going to a beach or on vacation or something, and I'm kind of going on vacation. We're taking a few weeks off, but it won't be at any beach, folks. It's because I'm expecting a baby on July 12th and probably sooner. My second child, my son, is coming into the world, so life is going to be a little bit hectic. So we will be back in July with new updates and a bunch of new information and a bunch of new guests and new shows. So stay tuned. We will let you know, of course, on the Facebook page, on our Instagram page, LinkedIn, YouTube, everywhere, Twitter that we are. We'll let you know when we come back. But this is our final episode for a while, and so I'm very excited about today's episode, and I hope you are too. Now, before we get started, we always like to thank our presenting sponsor, Jaydira Therapeutics. Folks, we could not do this show without them. Always a huge thank you to them, and always a disclaimer from them that we like to say at the top of the program, and that is that the opinions expressed by the guest presenters, as well as the questions asked by the audience, that's you all at home, haven't been created or suggested by the sponsors of Luncheon with the Experts, and CCF doesn't endorse or promote any of the views, opinions, or information expressed provided in the presentation. And audience members should not rely solely on the opinions or information expressed by the guest, and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. Listen, that last line is the takeaway. We're going to give you some good answers to your question and some advice and general direction for this journey that you're on, but by no means do we know your specific case. So take that information back to your home team who does know your specific case, and they and you together will make the best plan for you moving forward. Okay, today our guest is Dr. Jaydira Del Rivero. How are you, Dr. Del Rivero?
I'm good. Thank you so much, Rain. I have to say it's an honor for me to be here today. Thank you.
Yeah, it's an honor for us to have you. Absolutely. So for those at home who may not be familiar with you and your work, tell us a little bit about yourself and what you do specifically. And the way I like to phrase it is, what is the role you fill in the neuroendocrine tumor community?
Well, thank you so much for that question, Rain. And again, thank you to the Carcinoid Cancer Foundation for giving me the opportunity to be here today with you all. Yes, I am a medical oncologist. I currently work at the NCI, the National Cancer Institute. And my role in the NET community is that, my area of focus as well of research is in neuroendocrine tumors. At the same time, I am currently the principal investigator of a natural history study for neuroendocrine tumors for all ages, pediatric and adults. And one of the reasons why we're doing that is because we wanted to understand more about the biology of these neuroendocrine tumors to be able to develop more treatments for these tumors.
Got
I
it.
can still, talk more about it, but I just want to make sure that we have time for some of the questions.
Oh yeah. Oh, we're gonna have plenty of time. Plenty of time. We got a good crowd already showing up here today. Hello, Samantha from Fayetteville. Look, lots of North Carolina in the audience today. Love to see it. So, folks, here's the deal. Go ahead and start sending in your questions. We're gonna try to get to all of them if we can, but I'll go ahead and tell you we get a lot of questions every week, so inevitably we don't get to all of them. But doesn't mean that you still won't get answers to your question. So if we don't get to your question, or if you have a follow-up question, please reach out directly to CCF, either here on their Facebook page. You can just private message them, or you can also reach them at their website at carcinoid.org. I promise you they will do everything to get you the information, or the information of the person who gets you the information that you seek. Know that the video will live here. It'll be evergreen. It'll be under the videos tab on the Facebook page. And then starting Monday, as I already alluded to, we will republish this on YouTube for anyone that you know that doesn't have Facebook. Okay, so you can always watch this back. Just know that too. There's a couple of things I like to ask at the beginning of each show, and ask of you, and you all have been doing a great job of this. Again, this is our last episode for a few weeks. So if you know someone that would benefit from this, another patient, a support group leader, a caregiver, anybody that would benefit from this interactive one-on-one session, because that's really the value that we provide, is you can watch the video later, someone else can watch the video later and get good information, right? But the real value is being able to ask a question that you have with this expert that we have for 1 hour at our disposal. So if you know someone that would benefit from this, that isn't here right now, tag their name in the comments, share the video to them. Let's get as many people here as possible this final episode, so that we can really, give everybody the most value that we can. And then the second thing that I ask, and you all do a great job of this, but I'll continue to ask because it really, really helps me do my job, is if you see a question in the sidebar in the comment section that you also have, or you're also interested in, if you're like, oh my gosh, like, yes, I want that answer too, you can like it, you can love it. Facebook, there's a bunch of reactions that Facebook gives you the option to, but they all function the same way for me, and that is to let me know, like, there's a demand for this question. Like I said earlier, we get a lot of questions. We can't get to all of them. So if I see that 7 people have the same question, I'm going to make sure that we get that one across. So that helps me help you, which is my job. Finally, I always like to ask if you have you downloaded CCF's free Net Cancer Health Storylines app. This app is amazing. It's free. It makes it easy to record your symptoms, your medications, your nutritional concerns, your moods, all of that. So if you haven't, check that out as soon as you can. We'll put a link into the comment section. And that being said, if there's anything that is referenced today, a medication, an article, any resource like that, we'll try our best to put that in the comment section too, so you don't have to open up a new browser window and go search for it yourself. We'll do all the hard work for you. All we ask is that you share some time with us and ask your questions. We're here to serve you. So, Dr. Del Rivero, let me know a little bit more about, I'm always very interested in one's introduction into this field, right? I don't feel like, and maybe this will change with the more education people have about this disease, but I don't feel like people go into med school with the idea that I'm going to work with neuroendocrine tumors. Most of our guests, I've learned that somewhere along the way they get introduced to this, maybe by a mentor, maybe by a patient, that launches them on their journey in this community. How did you get started?
Oh, wow. Right.
Let's take it back.
So it may be a little bit of a long answer, but yes, well, initially before I was a medical oncologist, I did my endocrinology fellowship. So
Okay.
initially when I started my endocrine fellowship, my idea was to study osteoporosis. That's kind of like one of the ideas
Okay.
that I had when initially started my endocrinology fellowship. But once I start learning more about the endocrine system and seeing the different diseases related to the endocrine system, I start working with a NET expert. His expertise is in pheochromocytomas and paraganglioma. So pheochromocytoma is another type of neuroendocrine tumors. And he was my mentor through the time that I was doing my endocrine training. Then I left NIH. I did my endocrine training here at the NIH, and then I left and I was practicing as an endocrinologist. And I did that in New York City. I was working with Dr. Steve Liwoody, and he's also a well-known endocrine surgeon. An area of expertise is also neuroendocrine tumors. And at that time, being an endocrinologist, my job was to kind of like do all the hormonal evaluation to this different type of neuroendocrine tumors. And one of the things that I realized seeing all these patients was that we didn't have that many treatment options. I felt like there needed a room for improvement to develop more treatments for neuroendocrine tumors. So then I came back to the NIH, and I was fortunate to do my oncology fellowship training here at the NCI. And then after that, I stayed here, and I'm currently developing a program in neuroendocrine tumors. And one of the things that is so interesting about neuroendocrine tumors is that the patients, I mean, I just love interacting with patients with neuroendocrine tumors. They know a lot about their disease, and it's something that to me is very motivating to interact with patients with neuroendocrine tumors. Every day I learn something different, and every day I learn something new from patients as well. And it's something that to me is motivating me every day. I think that one of the things in terms of neuroendocrine tumors, and that's why, as I say earlier, I'm the principal investigator of this natural history study, which is a longitudinal study. We're studying patients long-term. And the idea is to understand more about the biology of these tumors. From the patient perspective as well, we wanted to understand if there is any environmental factors as well around the patients where they were diagnosed with neuroendocrine tumors. One other aspect of these natural history studies that we're doing a biospecimen collection in terms of collecting tumor to understand more about the molecular biology. We have our own molecular panel of sequencing for neuroendocrine tumors. At the same time, we wanted to understand more about what is the psychological aspects of around neuroendocrine tumors. If patients with neuroendocrine tumors have fatigue, anxiety, depression, that's kind of like patient-related outcome measurements. And that's something that we also want to learn by studying this patient population, because we really want to help patients with neuroendocrine tumors. We want to develop more treatment options, even though I have to say that in the last 10 years, we have been seeing an advancement in the treatments of neuroendocrine tumors. I do believe that there is room for improvement, and I'm hopeful about that. I'm sorry, I think that was a long answer.
No, hey, yeah, I said this last week with Dr. Julie Halle. It's like it's not a long-winded answer. It's a thorough answer. That's the way I like to look at it. And you know what? Our audience here likes being thorough, right? We're trying to help everybody. So don't you worry about that at all. Folks, if you've joined us later, just joining us, we are here. This is Luncheon with the Experts. We are here with Dr. Jaydira Del Rivero. And we're going to have a great show today. Go ahead and start sending in your questions. I see we already have a lot. So Dr. Del Rivero, we're going to go ahead and pivot to some of those questions. Two more things I want to let you all know at home about the questions. We can't get too case specific. All right. Our guest isn't your doctor. She doesn't know your guest. What was I gonna say? Your case. And so don't try to formulate your questions in a general way so that we can give you general advice, because there's a lot of information that it would take to really give you super specific answers to your questions. So just know that we're still going to try to help get an answer to your question, and we may need more clarification on some of them. Okay. But just know that if it's really case specific, it's not going to be really easy for us to answer. And another thing, folks, I am not a medical expert. Now, I've been working with NETs for 10 years, so I'm somewhat familiar with all the terminology, but I certainly don't get it right all the time. And if you write a typo, I will read it the way it's written most of the time. So do me a favor, just double check before you hit send if there's a typo, because sometimes I get a little bit of egg on my face. But that's why we have experts here to correct me, and I'm willing to fall on the sword for that. All right, let's get the questions going. So Florian, our friend from Germany, says, by the way, Florian, what city are you in? Just curious. Side note, Florian says, and a lot of other people have this question, what does the size of the tumor say about the severity of the disease?
Okay, thank you so much for the question, and I really appreciate the question. And yes, size of the tumors and neuroendocrine tumors, it is important. For example, for pancreas neuroendocrine tumors, we usually kind of have the cutoff of 2 centimeters in order to make the decision about whether we wanted to do surgery or not. And one thing about the size of neuroendocrine tumors that we know of, once the neuroendocrine tumors is resected, sometimes the size and the lymph node involvement help us to determine what will be the follow-up moving forward after the resection of neuroendocrine tumors. I think the way I see size of neuroendocrine tumors, especially for pancreas, I would say usually the cutoff is 2 centimeters in order to determine about surgery versus not surgery, or maybe observation, especially because we know that these neuroendocrine tumors are very slow growing tumors. But at the same time, once a tumor is resected, it's important for me to know the size plus other variables in regards to neuroendocrine tumors. What is the grade, if there is any lymph node involvement, because that way it can help me also determine what will be the follow-up moving forward.
Got it. Thank you. Thank you. And thank you for your question, Florian. Rose says, I had tumor debulking 4 months ago. The latest scan shows no tumors and I have no diarrhea or flushing. However, recent blood test shows serotonin over 1,000 and chromogranin very low, under 40. And I'm currently on 30 milligrams of octreotide. So why would serotonin be so high?
Yeah, well, that's a very good question, Rose, and thank you so much for the question. One thing that I have to say is, I don't know if a 5-hydroxyndolacetic acid was also obtained in the urine. It's also known as 5-HIAA. And the reason why I'm asking that is because when we measure the 5-HIA is the end product of the serotonin. So the serotonin is metabolized and then it goes into the urine, and we measure that in the form of 5-HIAA. Now, currently, we also have a blood measurement of this 5-HIAA, and we know that the sensitivity of how we can really value these 2 levels is the same. But one thing I wanted to say about serotonin is that sometimes if we have seen that the 5-HIAA is normal, but the serotonin is high. And why is that? Sometimes it's because handling, whenever we obtain the blood test and the way it's handled is very important. For example, if we kind of like obtained the serotonin and then we shake the tube where the serotonin, where the blood was drawn to measure the serotonin, sometimes there are breakdown of platelets, and then that will cause a false elevation of the serotonin without really have any meaning the functionality of the neuroendocrine tumor. So that's one thing that I will say. If we have a normal 5-hydroxyndolacetic acid and the serotonin is high, so maybe we can repeat again the serotonin with making sure that it's done in the proper way and handled in the proper way. At the same time, if we have a high serotonin, maybe it will be important to obtain a 5-HIAA either in the urine, in the blood, to really know what is the correlation. I don't know if that answered your question, Rose, but thank you for the question.
Yeah, thanks, Rose. Let us know if you have a follow-up question. Next question from Tanya says, why don't us cancer patients hear anything about this cancer spreading to the bones? I'm very concerned about my elbow and hip since they are both very painful and very weak now. And I will say, Dr. Del Rivero, the question or the concern of joint pain has come up a lot lately. So what do you think for Tanya? She's concerned about the cancer spreading to the bones because of pain in her elbow and hip.
Okay. Well, thank you so much for the question, Tanya. I appreciate the question. And one thing about bone pain, as Rain was saying, some of the treatments that we provide for neuroendocrine tumors can certainly cause that bone pain. One thing that we need to know, especially in well-differentiated neuroendocrine tumors, I think we know here in this community, is that well-differentiated neuroendocrine tumors can express somatostatin receptors in the surface of the cells, and then we can see that by doing a gallium scan or a dotatate scan. So I think one thing to know is that by doing that gallium scan, do we see any involvements in the bone? And that can cause some of the symptoms. It's possible, but that's something that we could investigate. At the same time, is my joint pain or my bone pain is related to the treatment, and that's something that we can definitely keep in mind as well. I think more important is for you to discuss this with your doctors as well, whoever is treating you in terms of neuroendocrine tumors, whether a gallium scan was done or 68 gallium scan was done, and we see something in the bones that may be causing the pain. So we need to explore that, or whether it's the medication itself that is causing that's something that we should definitely explore as well. If the medication is causing some of the pains, I think usually what we recommend is to take an analgesics, an NSAID like Tylenol, naproxen. Sometimes that help also for the pain.
Got it. Got it. Thanks, Tanya. And I see Tanya said a few little ways down that sorry for the typos. I just want to be clear. I wasn't directing my comment earlier at you specifically, Tanya. I just had a couple of tongue twisters last week. But thank you for your question, and hopefully that helps. And listen, this is one of those moments where typically in the show, one of my favorite things is the guest provides great information and answers, but also you all share your own experiences with each other, and that can be just as helpful. And so again, this question about joint pain has been coming up every week. So if anybody else has, experiences with that, or you want to, share your experience with Tanya, that can be very helpful too, because I know that this isn't unique to Tanya right now. So thank you, Dr. Del Rivero. Okay, Kathy says, I'm part of this natural history trial and have sent other patients to it. My question is, will the patients on this study get results of tests? A few weeks ago, I sent a DNA saliva sample to NIH NCI. Will I get the results of that DNA test?
Okay, great. Thank you so much for the question, Kathy. I really appreciate it. And if you have a follow-up question, just please reach out to me directly as well, and I'll be happy to answer any of the questions. But yes, so as part of the natural history study, one of the things that I mentioned earlier is that we obtained what we call biospecimen collection tumor. The tumor that we obtain, we usually send it to our panel. It's a molecular panel to understand if there is any mutations within the tumor. And I think it's important to differentiate the mutations that are within the tumor, which are somatic mutations, or whether it's germline. So when I say germline, it's like every cell in your body. And when that happens, that can also be, your kids can inherit that condition as well. That being said, something that I want to clarify is that less than 10% of neuroendocrine tumors may be associated with a germline mutation, and we can discuss about that later. But in terms of our study, first we sent our panel for this tumor for a molecular panel to understand if there is any mutations within the tumor. We do have a genetic counselor. Our genetic counselor is very detailed in obtaining all the personal and family history, and based on that information, we can then determine if further testing or germline testing needs to be done. The saliva that we ask for most of the time is research as well. So sometimes that you may not get an answer unless we feel that it's something that may be important for your health. We absolutely communicate all that with the patient, and our genetic counselor has been very good by communicating with the patient as well. If we don't find anything that is relevant to the patient, so that saliva will stay in our biobank, and it will be used for future research as well. But thank you so much for the question. I think just to summarize what I just say is that in terms of collecting the tumor, we sent for our somatic panel to see if there is any mutations within the tumor that can help us understand the biology of the neuroendocrine tumors. And also we sometimes collect saliva as well to do more of an extensive panel or more of a germline testing to see if it's everywhere in the cell. But that our genetic counselors help us to make that decision whether further analysis needs to be done. And she's an expert as well in neuroendocrine tumors as well, especially with germline associated neuroendocrine tumors.
Got it. Got it. Thank you. Folks, we are not quite halfway done with today's show. This is Carcinoid Cancer Foundation's Luncheon with the Experts, brought to you by Tercera Therapeutics. Today, our guest is Dr. Jaydira Del Rivero. And you're doing great sending us questions and getting us people here. Our numbers are looking good. Let me let you know one more thing that you can do to let us know we're doing our job well. Down there at the bottom of your screen on the Facebook Live, there's a handful of little icons. There's a thumbs up, a heart, a little emoji holding a heart, and a few other things. if we are giving you some good information, if you get a great answer to your question or something has been helpful, that's a visual cue that you can use to let us know we're doing our job effectively. You can send the little thumbs up, you can send the heart emoji, anything like that. It lets us know that that you're getting some value out of the show, which is 100% our top goal. Let's get back to the questions. We have an interesting one from Lynn here, who starts it off. Crazy question here. Almost 3 years out from major abdominal surgery, which started as a peanut in the tail of the pancreas with metastasis to liver, spleen, and gallbladder. To the liver, spleen and gallbladder removal as a precaution. No Whipple, though. I still have very tiny specks in my liver. Now, here's the question. Can amusement park rides like roller coasters shake and rattle these tiny tumors around and cause problems? Like, do NET patients need to walk and physically behave very careful all the time, or can we do something like ride a roller coaster? I've never heard this question. And by the way, Lynn says she feels fine.
Okay. Well, Lynn, it's good that you're feeling fine. And I think you need to go and do your roller coaster. I think everything is going to be just fine. But thank you for the question. You need to enjoy your life, go to amusement park. That's what is the most important that you need to do.
Sounds good. That's always the good news when you're when you can go on roller coasters. Coasters are always fun as long as you enjoy them. Dr. Del Rivero, at the beginning, when you were kind of telling us your background, you were talking about one of the things that inspired you to really want to work in and with this disease was the lack of treatment options. I mean, the problems and the challenges that caused. I'm curious, over the years, what are some of the treatment options that have become available that you think have really moved the needle forward for this disease and treating this disease?
Great. Thank you so much for that question, Rain. And I think that's a very important question. And one thing I have to say is that the development on treatments of neuroendocrine tumors in the last 10 years has been very exciting developments. I think one thing that I have to mention is about the approval of PRRT with luthothera. So as peptide receptor radionuclide therapy is a type of treatment. So some people, they want to call it PRRT, some other want to call it luthothera. I know that there are different names for this, but luthothera is a type of PRRT. I think that definitely has been a good advancement in terms of the neuroendocrine tumors. I think that patients has this availability in terms of treatments. We have seen that luthothera works for neuroendocrine tumors, stabilize the tumor for longer times. The response rate is less than 20%, even though we know that luthothera works. One of the things that to me is exciting about what the research is moving forward is about how we can make luthothera more effective. And that's one of the things that even here at the NIH, we're trying to also understand that part of how we can make luthothera more effective, and working with Dr. Franklin, who is our nuclear medicine physician here, and who is also the PI of a lot of our luthothera treatments. Also, the question here is, like, we combining the treatment with other agents, can we make luthothera more effective? I have to say that I'm very excited also about Dr. Shahan's studies as well. He has a study of luthothera in combination with triapine as well. And I really am looking forward to know the results of that study, because the goal is also his goal is also how we can make luthothera more effective, the same with us. And one of the things I wanted to explain, if it is okay, if I have a minute, Rain.
Absolutely, you have all the minutes.
Why we wanted to do that, why we wanted to make luthothera more effective. And one of the things is that in terms of understanding the biology of how luthothera works. So we know that luthothera is a type of radiation. So whenever we give this luthothera, it goes into the body, it goes and binds to the receptors of the neuroendocrine tumors. But sometimes when the body sends that radiation, and this radiation nicks the DNA, so it causes DNA damage, the body is trying to repair itself, trying to repair that DNA damage. And sometimes with these other medications like olaparib, that's the one that we have here at the NIH, or triapine, that's the one that Dr. Shahan has at University of Kentucky, is trying to prevent that repair. And that means that with that repairing that repair can make luthothera more effective. And I think that's one of the exciting things that I can see, that I'm looking forward to know more of the results about this. One other thing that I wanted to mention as well is that at the European Neuroendocrine Tumor Society, they also discuss another treatment, which is surufatinib, which is in the family of the vascular endothelial growth factors inhibitors, or a TKI. So that means that it blocks the vessels of these neuroendocrine tumors. And it seems that there has been some exciting information about this drug that is not only for the pancreas, but it's also for the lungs neuroendocrine tumors, as well as for the small bowel neuroendocrine tumors. I think that's something that could come. The question is, like, what will be, when can we use this one in terms of the treatment algorithm for these neuroendocrine tumors? But I think there is a lot of things coming up in the pipeline for the treatment of neuroendocrine tumors. And I think we're in exciting times as well. A lot of our colleagues are working, very hard and also to understand more about these neuroendocrine tumors and how we can develop more treatment options.
That's awesome to hear. And special shout out to Dr. Roman Chouan, who I believe is in the audience today. And he's often in the audience. I think he just likes to make sure, I'm doing my job well and keep me on my toes. But he is definitely a buddy of mine and a friend of the foundation, and a great member of the NET community. Such a great guy. So
Dr. Shahan is amazing, and he should come here. Dr. Shahan, come here.
Are you recruiting him right now?
Yes.
Well, if something happens, we'll know it happened here on the show. Okay, next question from Darina. Darina says, what resources does the NCI have for patients with neuroendocrine tumors?
Very, very good question. And I appreciate the question. So in terms of resources for neuroendocrine tumors, one thing that I have to say, the NCI overall can give a lot of information for any tumor type. One of the things that I always advise my patients in terms of education is to go to the cancer.gov. There is also a number that you can call, and it's available 24/7 in order to obtain more information about the specific type of neuroendocrine tumors. And I have gone there, and I know that if you type neuroendocrine tumor, there is a lot of information about it, what it is, what clinical trials are available also for neuroendocrine tumors. In terms of the work that I'm doing, so we have the natural history study. We are seeing a lot of patients with neuroendocrine tumors as well. We're providing an expert opinion. One thing I have to say is that I have amazing colleagues that I work with that also, they have an expertise in neuroendocrine tumors. Every Thursday, we have our tumor board we discuss all type of neuroendocrine tumors. On that tumor board, we have the surgeons, the endocrine surgeon, the pancreas biliary surgeon, we have the endocrinologists, oncologists, we have interventional radiology, nuclear medicine, all the experts that can provide an opinion of what will be the best treatment to follow or treatment algorithm for a specific patient. I have to say that in terms of the management of neuroendocrine tumors, I think you all have heard that they're very heterogeneous. It's a very personalized type of treatment. So that's the reason why I think one of the recommendations is whenever we discuss a patient with neuroendocrine tumors, that needs to be discussed with a multidisciplinary team. And I have to say, I'm very fortunate to work with a great group of physicians here who has the expertise as well as the knowledge in neuroendocrine tumors. And that's something that we discuss every week. Every Thursday, we have our neuroendocrine tumor. We always have a large list of patients that we discuss. Also, we're developing clinical trials as well for neuroendocrine tumors. I think I discussed earlier about the luthothera treatment in combination with olaparib, which is a pill for neuroendocrine tumors. We're planning to recruit patients in the next 2 months.
Oh, wow.
We also have a luthothera treatment for pheochromocytomas and paragangliomas. That's another treatment that's available here. We're still currently seeing patients with pheochromocytomas and paragangliomas. That's another just to mention, pheochromocytomas, they express also somatostatin receptors very similarly to neuroendocrine tumors, and that's a treatment that we're providing here in the in the setting of a clinical trial. I'm also the co-PI of another treatment study for pheochromocytomas and paragangliomas with Dr. Perez, who she's a Dana-Farber, as well of chemotherapy, combination chemotherapy as well for pheopara. I think one thing that I'm very proud to say is that we are now learning more about these neuroendocrine tumors. And because of that, we're now working with a lab here. I have to say that I have some colleagues that works in the lab that we're trying to do some drug testing as well for neuroendocrine tumors with the goal to be able to develop personalized treatment for neuroendocrine tumors. I'm excited to say that that's something that we're doing here. And I have wonderful colleagues that are working as well to understand more about these neuroendocrine tumors.
Awesome. Great question, Jaydira. Really quick, Dr. Del Rivero, the trial that you mentioned with the combo pill and luthothera treatment that you said is coming up in 2 months, I believe. Is there somewhere that people can find out more information about that if they were interested in participating possibly?
Absolutely. And I should be able to provide maybe this information. I don't know how I can. One thing that I can recommend is to go to clinicaltrials.gov.
Sure.
If you type luthothera in olaparib, should be able to be there,
Okay.
and the contact information is there.
Cool.
Otherwise, I mean, if I'm able to provide this information, I'm happy to maybe at the end of the show to provide more information about it.
Usually are the engine behind the foundation. Grace Goldstein is on the back end adding links and stuff like that. So usually before I even finish a question, she's
That's awesome.
added that. So as I continue to scroll through the questions, I'm sure I'll see something
Great.
in there from her. But yeah, clinicaltrials.gov is always a top resource for that. Speaking of resources, just to let you all know, you mentioned something, Dr. Del Rivero, about multidisciplinary teams. We know how important that is here at the foundation. Here on the show, we talk about it every week. One of the many resources that CCF has for you all at home is the video content that I've been helping them produce for a decade, like I mentioned in the top of the program. So you can find those under the videos tab on Facebook, and our older ones are on the YouTube channel, which is growing, and we're really proud of that as well. But we have so many videos of different aspects of this disease. We did a series in 2018, an award-winning series that was very patient-centric, but we also have done over 10 years a lot of very treatment-centric videos. And one of the videos that we did in 2019 and 2020 was specifically about multidisciplinary teams and the importance of them, where you can find them, who is included in them, all of that stuff. And we covered in this series, we had one on surgery, on NETs in children, on PRRT, on pretty much everything that you can think about. So just know that we have endless resources here at the foundation that will help you in this journey. That is our job. That is our mission. Let's get back to some questions. This show continues. Kim says, this is a question on behalf of her dad, I believe. My dad had a gallium scan and it revealed multiple bone metastases.
Mhm.
Now, he has been started on lanreotide, and this may be difficult to answer, but do bone mets automatically worsen prognosis? Because he is overall without symptoms and his blood work remains stable since this was caught incidentally about 7 months ago.
Mm. That's a very, very good question, I have to say. And I don't know if I know the answer to that, but something I can say is that specific question, that's something that we're trying to analyze with our cohort of patients here. One of the things that we want to do that we're also starting to analyze is a different type of metastasis, whether it's the lung, whether it's the bones, whether it's the liver, and also understand what is the prognosis overall. And that's something that we're currently analyzing, and I hope that I can get a better answer a few months from now. Okay. But for now, that's a very good question, and I have to say I don't have a specific answer right now, but I'm hoping that in the next few months I can have a more concise answer about it.
Great. Yeah, thanks for that. And thank you, Kim. You are on the right track. Great question. And yeah, like Dr. Del Rivero said, maybe we will get that answer to you very soon. So stay tuned and stick with us. Jennifer says, if chromogranin A levels are over 2000, is this an indicator to do a debulking?
Good question, but yes, I think that I assume that when you're talking about elevated chromogranin already in the, already have the diagnosis of neuroendocrine tumors. But I have to say that I don't know if chromogranin A is a very good biomarker that we use. I have to say that most neuroendocrine tumor experts don't really measure chromogranin A. I personally don't measure either. And the reason why is because we know it's a biomarker that has been around for many years. But one thing is that this can be affected by different, by food, by other medications, such as what we call the group of the PPIs, which is the omeprazole and suprazole. All of that medications can definitely raise the chromogranin A in the thousands. And I think that that's one thing that most NET experts doesn't really rely on the chromogranin A. I personally don't really do it routinely, but that's something that I have to say that unless there is evidence, unless you have symptoms, unless there is something that on the CT scan is telling me that you may have neuroendocrine tumors, of the neuroendocrine tumors is getting worse, I may not necessarily, be too worried about the number. But again, it's something that definitely you need to discuss with your physician. Definitely something that I also don't want to ignore, something always that we pay attention. But I think that I will not be as concerned.
Got it. Thank you. Thanks, Jennifer. Erica says, can a patient with diagnosed with a grade 1 tumor later develop a high grade tumor?
Mm-hmm. Very good question. I think this audience, can I ask you something, Rain? Is the audience always ask this very, very good question?
Yes, they're very well educated. They keep us on our toes. Absolutely.
Thank you so much for all of these questions. This is good. This is great. And I think that overall, one of the things in terms of neuroendocrine tumors, we also need to establish what is the biology of neuroendocrine tumors, meaning like how these tumors are going to be growing over time. Sometimes in the rare occasions, these tumors may be well differentiated for long periods of time. And sometimes we see like, oh, maybe some of these areas may be a little bit more growing a little bit faster, in that sometimes that may be an indication for us to do a biopsy to understanding maybe the Ki-67, which the Ki-67 tell us as well what is the differentiation is a marker that helps us to understand more about how the cells are able to replicate. But overall, I don't think I have seen a lot of changes going from very well differentiated, rapidly going to poorly differentiated or more aggressive type of tumor. But sometimes in the sense that I see that everything is stable, and I see like some of these tumors may be a little bit growing more rapidly, that may be an indication for me to do a biopsy just in case to see if the numbers change. But overall, I have not seen something that changed that dramatically. I don't know if that answered the question, but thank you for the question.
Absolutely. Next question from Suzanne. Suzanne says, if the primary tumor is not found, is there any treatment that can be done, or do you continue dealing with the flushing, the tiredness, etc., with just checking in with your doctor once a year for blood work and a CT scan?
Mm-hmm. That's a very good question as well. And one of the things is that I do have seen quite a few patients and where the primary tumor has not been found, in the sense that they already come with symptoms of related to excess of serotonin, they have the diarrhea, they have the flushing, and they already see the tumor in the liver. But one thing I have to say is that sometimes a gallium scan can definitely help us as well to know more about the extension of the tumor. It's possible that, especially in the setting of having excess of serotonin, that maybe the neuroendocrine tumor may be very small and maybe in the bowel, and sometimes the galliums can help us to determine that. Mm-hmm. But in the sense of, finding the tumor, but you already have more of extensive disease in the liver and so forth, I think it's important to continue following with your doctors, continue follow with the scans, and possible doing a gallium scan. If you have not done a gallium scan, I think that would be important to obtain.
Got it. Let's see, folks, we got about 15 minutes. We're going to keep pushing forward with questions. You all are asking some great ones today. Let's see, Dorinda or Dorinda says, I'm a participant in the NIH study, and my oncologist, though, is not a net specialist. Would you suggest a second opinion with a specialist?
Yes, I mean, I think it's always important for uh, any neuroendocrine tumor patients to see or seek the expertise of a net expert. If you were a patient of NIH and you want to be seen by me, I think that would be something that I'll definitely, you know, you can definitely come to the NIH for a consultation. And sometimes that we do is that we work with oncologists on the outside. We sometimes provide an evaluation, we provide a guidance. And then after that, what we do is we work with oncologists or the local oncologists, and we work as a team. I think it's important. One of the things that I do recommend to my patients is to find a net expert. So that way, now with one of the things about COVID is that now you can do a telehealth visit, and then you can reach out to Dr. Chauhan, and Dr. Chauhan, I'm sure, will be happy to provide an opinion via telehealth visit. And that would be something that you can work with your local providers. The same with me, and always willing to work with any of the local oncologists in order to provide a guidance and support for patients with neuroendocrine tumors.
Awesome. Thank you. Melvin says, do you ever hear of net tumors or neuroendocrine tumors in the spine?
Very good question. I have to say that I had seen one patient that it had a neuroendocrine tumor that was only localized in the spine and one of the vertebrae and in the back. All the workup, gallium scan, colonoscopy, endoscopy, all the workup was done. We couldn't find the primary, but it's only localized on the spine. That tumor that was localized was resected as much because there was some what we call soft tissue components, in the sense that there was some tumor that was coming out of the spine that was resected, and then the patient had radiation, and I'm still following this patient. Again, one of the questions is like whether the primary will be some other place, and that's something that we're trying to understand. That's the only one patient I have seen. I will be curious to know if any other net experts have seen that, but that's very unusual case, and I think that I don't think we see that very often.
Yeah, interesting. That's something new for me to learn today. Melvin, I'm curious what prompted that question, especially since it's been, it seems so rare. But thank you very much for sending it. Next question from Eva. I am a PNET with 2 primaries. Pancreastatin is high. I am non-functional. What other tests should be done for surveillance?
So, right, can you repeat the question? So, pancreatic neuroendocrine tumor that was resected?
PNET, two primaries, pancreastatin is high, and I'm non-functional.
Okay, pancreastatin is high. Okay, so talking about pancreastatin, so pancreastatin is the way I see it is kind of like similar to chromogranin A, but it doesn't have the it doesn't have the interference of other medications, of other drugs. So as we know, chromogranin A can be easily affected by medications, where pancreastatin not necessarily. I don't know, is that here we don't use pancreastatin very often, but one thing is that once the pancreas neuroendocrine tumor was resected, one of the things that they need to know is, we discussed a little bit this earlier, is the size of the tumor and whether there are lymph node involvement. Because I think the question is that how often do I need to follow in terms of if there is any recurrence of this neuroendocrine tumor. So if there is the pancreatic neuroendocrine tumor was resected, it was small, there was no lymph nodes, the likelihood of recurrence is less than 20%. And in those situations, I still want to do surveillance at least for 10 years. One thing about neuroendocrine tumors is that sometimes we can see a recurrence even past those 5 years. And I think it's important to continue with scans. Timing is another thing that is important, that we discuss how often do I do this type of scans. I think for the first year or so, we can do it every 6 months, but then after that, we can do it every year. And then after after certain 5 years, maybe we can do it as needed basis. Now, if the pancreas neuroendocrine tumors is a little bit larger, and then if we see some lymph nodes, the likelihood that it can have a recurrence is more than 60%. So in those situations, we need to kind of like understand what is the biology. Maybe we need to do scans a little bit sooner. One other question that sometimes I get asked about it is like, do we do CT scans? Do we do MRIs? I think one of the things is about the radiation exposures and the concern about that. And it's okay to do MRIs as well in order to continue with what we call the surveillance type of phase of the neuroendocrine tumor.
Got it. Thank you. And thanks, Eva. Hope that helped. Next question from Steven. Steven says, after removing a primary carcinoid tumor and affected lymph nodes, is there a treatment for reducing the chances of recurrence in the liver? For instance, such as low dose octreotide or something like that.
Yeah, that's very, very good question. Thank you so much for the question. And I have to say, this is something that even I had discussed with other colleagues, because we have seen, or I have seen quite a lot of patients that the neuroendocrine tumor was resected, that there is lymph node involvement, but then everything was resected and we don't see anything. And the question is, do we need to give some in the injection, the lanreotide and sandostatin? And usually the standard practice that I do for in those situations is, unless I can see something, I don't necessarily give the injections. However, we still need to continue doing scans in order to really know. Sometimes it may, even with lymph nodes, maybe we don't see the neuroendocrine tumors, and it may never happen. But at the same time, we need to make sure that we follow this over time. Now, if we see the neuroendocrine tumors that we see in other places, they go to the liver. First thing is understand the biology, how these neuroendocrine tumors tend to progress over time, to then decide when will be the time to give this type of injections. But overall, I think the answer is, if the tumor was resected, there was the lymph nodes, but also was resected, and I don't see anything on the scans, I just continue monitoring without giving any injections.
Got it. Thanks, Stephen. And Stephen, I think that you may have sent that question before or earlier, and if that's true, that's a really good, way to bring it back up. We get so many questions when they start coming in fast. Sometimes, well, obviously we can't get to all of them, and like I said at the very beginning, I try to get to the ones that are in the most demand. But it looks like you may have reformulated that question and sent it back, and that was a job well done. I just wanted to let you know that helps me out a lot, so I appreciate you, and I hope the answer helped you as well. Darina says, when I look through the specialist list on the CCF website, I don't see any gynecological surgeons listed. Are there any OBGYN surgeons who focus on NETs?
Yeah, that's a very good question. I think very good question. I think one of the things that and Doreen, I really appreciate all of the questions that you're asking today. But I think one of the things about neuroendocrine tumors, and maybe you have heard this before, is it can occur anywhere in the body. And it can also affect areas in the cervix, or it can any women's part. It can also affect that as well in terms of neuroendocrine tumors, because these neuroendocrine tumors can be anywhere in the body. Usually, sometimes we have seen neuroendocrine tumors in the ovaries, and sometimes I do have, at least here in my area, I do have a good GYN that works with me in those situations. I particularly don't know anybody who really only focus on neuroendocrine tumors, but I think it's important that as your doctor who's treating you, that you have a group of doctors that they can communicate all the time. I think communication is key. In order to formulate the best plan for our patients. And again, I have seen patients with ovarians and low-grade neuroendocrine tumors, and I work with a very excellent GYN in the area. But again, I think that's something that needs to be discussed individually with each of the doctors.
Got it. Thank you. Question from Rose. How often should a gallium PET scan be performed? MRI and CAT scans are regularly scheduled every 4 to 5 months. What about a gallium PET scan?
Yes, great question. I have to say that this is just my practice, and in terms of the gallium scan, I always like to obtain a baseline gallium scan, especially for the well-differentiated neuroendocrine tumors, because those are the ones that express the somatostatin receptor. I always like to obtain a baseline scans just to know what is the extension of the neuroendocrine tumors. However, the gallium scan doesn't really tells me if the tumor is getting bigger, if the tumor is getting smaller, but the frequency of the gallium scan that I do is like once I see any changes on the biology of the tumors, or once I see that there is on the CT scans that there is some enlargement, or I see any new lesions, maybe at that point I can do a gallium scan. The gallium scan is important to do for two reasons. Number one, to determine if they express somatostatin receptors as well, obtained as a baseline, but also because we have the treatment with luthothera. And the question is like, when to do the gallium scan that can help us also to determine about if the patient may benefit from a luthothera treatment. But I have to say, I don't do it very often. I think in the past, they used to do it every 6 months, every year, but that doesn't really change much the biology of the tumor. I think one thing is like, we always obtain a baseline, and then the subsequent gallium scans will be as clinically indicated.
Got it. Next question from Jennifer. Jennifer says, Luthothera has affected my white and red blood cell count. What options do I have? Could I do another series of 4 treatments with intervention of bone marrow transplants or some other mediation?
Right. Yeah. Very good question. And that's true. I mean, what is the effects of luthothera? What is the side effects of luthothera? And one of them, it can affect the counts. And why is that? Because luthothera is a type of radiation treatment. It can affect those cells that are more rapidly dividing cells. And some of them is the white blood cells, the red blood cells, and the platelets. Now, usually for luthothera, the platelets seems to be the most affected. Sometimes when we treat somebody with luthothera, we see these changes on the white blood cells, red blood cells in the first 4 to 6 weeks, but it usually tends to recover after the 8 weeks. But one thing is that once we know that the patient benefits from luthothera, we know that it's beneficial, and the platelet counts is not completely recovered, we usually like to see platelet counts greater than, the number is greater than 75,000 platelets. One thing that can be done is to lower the dose, of give half of the dose of the luthothera as well. I think that's something that needs to be discussed with your doctor as well, especially if you feel like the luthothera has been beneficial to you, and we can discuss about the retreatment part. But I think, and as we discussed, platelets usually tends to be the more affected. And I think in those situations, and that's kind of like what the FDA level also say, that maybe lowering, give half the dose may be indicated in those situations, or in those patients that may have kidney insufficiency as well.
Got it. Got it. Next question, probably getting close to our final question. Diane says, earlier we talked about net tumors in the spine, which is a rare situation. Diane says, can net tumors be found in the brain?
So, well, very good question. It's very, very, very unlikely. Sometimes it can be found on the bone part of the skull, but not necessarily in the brain parenchyma, the brain. So it's very unlikely that we can see metastasis to the brain. I think more that we can see when it goes to the bone, as I say, it could be the skull, but not necessarily the brain. Very, very, very unlikely.
Got it. Got it. Dr. Del Rivero, what would you say to a patient who just got diagnosed with this disease? They're unsure of what it is. They may have never heard of it before. What's that first piece of advice so that they can give themselves the best chance at a great quality of life while dealing with this disease?
Yeah. Oh, thank you so much, Rain, for this question. I think it's a very, very important question. Once a patient has a diagnosis of neuroendocrine tumor or neuroendocrine cancer, it takes a toll emotionally, personally, having the diagnosis. I think one thing that I recommend to my patients whenever they are recently diagnosed with neuroendocrine tumors, number one, look for a net expert that can also work. I understand one of the difficulties in the treatment of neuroendocrine tumors is that sometimes they need to travel long distances in order to see a net expert. It may not be, it may not be something that may be close by to you. And that can also be a struggle for some of our net patients as well. But I think, as I say earlier, now with COVID, I think now there's a lot of these net experts that can provide a telehealth visit. And I think that would be important. I think first it's important to find a net expert and somebody that can also work with your local oncologist as well. Second thing, organizations like this one, with like the Carcinoid Cancer Foundation, I think has been extremely important and great support for all neuroendocrine tumor patients. There are other net organizations, but I think it's very important that you find an organization that you feel comfortable with, that you can discuss. Because one thing about neuroendocrine tumors is not a very common, it's not like colon cancer, breast cancer, and sometimes patients tend to feel isolated. And that's something that by being involved in these type of organizations can definitely help. Education is important, knowledge is power, and I think it's something that I always tell my patients. And I think the third thing about it is that we have a lot of net experts that are working hard to find better treatments for neuroendocrine tumors. And I think there is a lot of hope there. We're in very exciting times, and we are understanding more about the biology of neuroendocrine tumors, increasing awareness about neuroendocrine tumors. I have to say that this year at one of the oncology conference that happened in January is the gastrointestinal ASCO meeting, and Dr. Coons they gave her a platform to discuss about neuroendocrine tumors. That's important, education, awareness. But I have to say that yes, we're in very hopeful times, and I think that there's a lot of net experts that are working very hard to develop more treatment options. So, and reach out. I think it's important that you reach out, talk, tell us how you feel, tell us what is concerning to you. I think that's important, and the net community, they're willing to help. I think that's one of the things that I have seen about everybody that I have talked to, and they are always willing to help. So reach out. That's very important.
Yeah, well, we just got a flood of heart emojis to that last line. And Karen says, thank you, Dr. Del Rivero and Rain. I hope one day soon we will have a cure for this rare cancer. I hope so as well. And it sounds like what Dr. Del Rivero said. It gives us hope for that. And I know that we here at the foundation will continue fighting the good fight and informing people and raising awareness so that hopefully we can achieve that goal. Folks, that is our show for today. And listen, but if you weren't here at the beginning, I want to reiterate that we are taking a few weeks break. We will be back in towards the end of July. Well, of course, we will let you know with plenty of announcements. If you don't subscribe to the newsletter, you can find that at the website, carcinoid.org, or just stay tuned here on Facebook or any of our social media channels. Dr. Del Rivero, thank you so much for joining us today. We appreciate your time, appreciate you being here.
Thank you so much for having me. Thank you. And again, it was a pleasure being here. Congratulations on your son.
Thank you.
And, please, we're here for you, and I'm happy to be here. Thank you.
We're a community, right? We're a community. And thank you all at home as well, big part of the community, for joining us today. As always, we hope that this program helped answer some of your questions. And if you have follow-up questions, I reiterate to reach out to Carcinoid Cancer Foundation at carcinoid.org at their website, or you can just send them a private message here if you have any further questions. Thanks, as always, again, to our presenting sponsor, Jaydira Therapeutics. We could not do this program without them. And finally, my name is Rain Bennett. I am your host. Thank you for watching, and please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everybody. I'm going to go try to have a baby in July, so we'll see you later. Take care, everybody. Bye-bye.